Major difference between autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease is the fact that dominant presents during adulthood and recessive will be in a fetus. So usually you'll have a question that is saying there's this fetus and or there's oligohydramnios, so what kind of complication can take place? So then the answer will be pulmonary hypoplasia that is present in Potter syndrome. So that is the kind of question that can come. And PKD1, all these, the genes have come, the chromosomes have come. So now let's read through this. So renal cyst disorders, autosomal dominant polycystic kidney disease, numerous cysts in the cortex and medulla, but here in recessive it is cystic dilatation of collecting ducts. So here is cortex and medulla, and here it's collecting ducts. Now another very weird thing is in case of tubulointerstitial autosomal dominant kidney disease, it is medullary cystic kidney, but here since it's in the medulla, like the medullary cysts, it is medullary cysts, it is not very well visualized. So that is like a point of contrast between all the three. So let's get back to dominant. Numerous cysts in the cortex and medulla, it causes bilateral enlargement of the kidneys. Both cause that, ultimately destroying renal parenchyma. Presents with flank pain, hematuria, hypertension, urinary infection, progressive renal failure, approximately 50% of the individuals. So these are the presenting features. Now come back to this and look at the presenting features of recessive, autosomal recessive polycystic kidney disease. It often presents at infancy. It's associated with congenital hepatic fibrosis. Oligouric renal failure in utero can lead to Potter syndrome. It is associated with oligohydramnios. So you have all these features. Next comes the genetics. So mutation in PKD1, 85% of the cases chromosome number 16, PKD2, 15% of the cases on chromosome number 4. Complications include chronic kidney disease, hypertension, very obvious in the elder population because of increased renal production. Renal RAS, you have to think about from the RAS system point of view as to how this hypertension is caused. And finally, the associations. The associations are very important. You have a question in USMLE also on this. So, associated with Berry's aneurysm, that is subarachnoid hemorrhage, mitral prolapse, benign hepatic cysts, and diverticulosis. Here, it was hepatic fibrosis in case of recessive. And beyond the neonatal period, in case of recessive, you have systemic hypertension, progressive renal insufficiency, and portal hypertension from congenital hepatic fibrosis that was caused earlier. Now, the genes are very important in this case also, PKHD1 and 6p chromosome. Fibrocystin and polydactin are the proteins that is defective in polycystic kidney disease that is of the recessive type. So, these two are very important. Next is dominant. In case of dominant, the treatment is if hypertension or proteinuria develops, then it's treated with ACE inhibitor or ARBs. Now, remember the complications. In dominant, it's Berry's aneurysm, while in recessive, you have Potter sequence. In Potter sequence, you have pulmonary hypoplasia. So, this is important. Next comes this is, you can just read through this: autosomal dominant tubulointerstitial kidney disease, medullary cystic kidney, tubulointerstitial fibrosis, progressive renal insufficiency with inability to concentrate the urine. Obviously, because it's the medulla. Medullary cysts, they are not visualized, smaller kidneys on the ultrasound. These two are bilaterally enlarged, but this, it's supposed to be smaller kidneys on the ultrasound. And finally, poor prognosis. Next, you have simple versus renal cysts. Simple cysts, they're filled with ultrafiltrate, anechoic on ultrasound. Very common. This is simple. Microhematuria asymptomatic. While complex cysts, they usually are associated with renal cell carcinoma. Now, the a very small write up on ADPKD, that is autosomal dominant. So, the most common is CVS complications, and it is an incidental diagnosis, usually adults, it happens in adults. PKD1 that we studied earlier was more severe, and RCC that takes place is associated with sarcomatoid ADPKD. I think this much should be enough. And yeah, here another association is Cadley's disease, dilatation of intrahepatic biliary duct. It is seen in ARPKD, medullary sponge kidney. So I guess this much is enough for this page number 627. And this we deal with later, renal osteodystrophy, and hope you found value in this. It's a very important topic for NEET PG, as you can see. Revine's criteria has come earlier, so you can see this as well. It hasn't come for a very long time, but yeah, somewhere down the line it did come. That is, age in the Revine's criteria is the imaging findings and what age you can get this in. So 15 to 39 years of age, you can get a total of more than equal to 3 cysts, unilateral or bilateral. 40 to 59 years, more than equal to 2 cysts in each kidney, and more than equal to 60 years is more than equal to 4 cysts. So as the age progresses, autosomal dominant type progresses. So that is the main crux of the whole thing, that berry aneurysm is associated with dominant type, and with recessive you have the Potter sequence. And if I could, I'll just, okay, that's fine. I think I'll stop the video here. Just go and check out Potter sequence. It is very important.